Joining us today. My name is Boris Vilgorin, and I'm with CTAC and MICTAC, and I'm joined today by a couple of my colleagues from CTAC and MICTAC, and that's Yvette and Brianna. We're also joined by our colleagues from OMH. And again, thank you for joining us today for the Article 31 Clinic listening session. Just as a quick kind of reminder, these sessions, as we are actually doing them throughout the state, these are really a follow-up to our regional in-person sessions that were offered earlier this year. Even though it feels like we did them 3 years ago, but my colleagues keep reminding me that it was actually earlier this year that we did them. And these are the follow-ups to those, as I think if you attended those sessions with us, we did talk about coming back and having ongoing conversation, and here we are. And you'll hear us talk about that here as well, because this is also not the end of the conversation, but just a continuation, and we'll be having more next year. So today's session will focus on areas related to access engagement and return to treatment. So we'll talk a little bit more about what that means throughout the presentation and the day. And again, not only this is, we have folks from CTAC and MICTAC, like myself, Yvette and Brianna. We have folks from OMH, as I mentioned, and both from central office and the field office staff. Again, just following the same kind of concept and an approach we did earlier during those in-person where all of us feel that we all need to be in the same room, making sure hearing the same message, and kind of talking with one voice here. So again, we have folks from both central office and field office, and we also have folks from Psyches joining us. We know that Psyches is also doing a project around this engagement piece, and we wanted to make sure that we're very much in line with Psyches folks as well. So wanted to welcome some of our Psyches colleagues to the call. Um, Today's conversation, and I say conversation because we do look forward to having really a robust conversation. There's going to be a component of presentation, but really, we really ask you to be prepared to actively engage and share your experience throughout the session. This is, the reason we called it listening session rather than, kind of a presentation and so forth. If possible, and you have a capability, we do ask that you put your video on. We do find it extremely helpful as we engage in this robust discussion. And again, trying during these times to make this as close as possible to kind of the in-person events as we can. Just give you a little bit of a breakdown. Um, so today's session is separated into three parts. The first part will be kind of a little bit of that formal opening presentation, which will be done by OMH. We will then have a breakout rooms that folks will be randomly assigned to have a discussion. After the breakout rooms, we will all reconvene back to one area for report out and really talking about next steps. And we'll go through some of this again later just to make sure folks kind of understand what's happening and where you're going and what's going on in the next, really 2 hours that we have together. So during the opening presentation, we are going to be recording the opening presentation, and we'll be making the slides available after we conclude all of our regional sessions, which are slotted to finish a week from Friday. And so after that, we hope to have both the recording and the slides available for kind of the opening session. During the opening session, please feel free to chat in questions or comments throughout that presentation. Again, when you do use the chat box, please chat your questions and comments to everyone, and we will try to address the questions at the end of the presentation or during our Q&A section at the end of the whole session, or even during our breakout. Just a few housekeeping items again before we get started. During the second part, when we do go into the breakout rooms, each room will have a facilitator or sometimes multiple facilitators, you will actually have the capability to unmute yourself during the breakout rooms. And so we ask folks to do that because, again, we just want to have that robust conversation. But because you do have that capability, we just want you to be mindful, kind of the potential noise and surroundings as you unmute yourself. At the end, when we reconvene, we will keep that capability open, meaning that you will still be able to unmute yourself, as well as continuing to chat if that's you feel more comfortable doing that. So at the end, we could continue having that robust conversation. And lastly, especially folks that are joining from the field office, OMH field office, or some of the central office folks and psyches, and we ask that if you can, put your title and name next to, actually, I should say next to your name, put your title, or if you're from field office, next to your name, so we can know who you are, especially when we have breakout rooms. We want to make sure we assign you appropriately. And you can do this by clicking on the More button next to your name and renaming yourself by adding, field office, central office, psyches, and so forth. And we actually want to open that to everybody. And so if you're interested, and it would be, again, helpful to us if you would like to add your agency next to your name as well, that would be greatly appreciated. So looking for that, again, if you're interested. And lastly, if you are experiencing any technical difficulties during this event, please write directly to MICTAC admin for assistance, and we'll try to assist as best we can. So I think I covered all of the kind of the basics and housekeeping. And with that, I'll be turning this over to Stacy, who will take us through the first part of the OMH opening presentation.
Great, thank you. And I just want to thank CTAC, MICTAC for all your work on helping set this up. We had our first listening session on Monday, and we heard some really good feedback about the technical piece of the Zoom meeting. So appreciate it, and I think it went really smooth. So here's for another really good listening session. So I just want to welcome everybody. I am Stacy Hale, the Unit Director in the Bureau of Rehabilitation Services and Care Coordination. And just to start out, I'll talk a little bit about some of the work OMH has been doing with clinics, working really to improve documentation requirements and remove other barriers that might get in the way to access and treatment, and the work that clinicians are doing. And, in doing that, some of that work can be done now, and it can be started. And so that's why we're talking about this in some listening sessions, especially with the recent reg changes back in August of this year, where we focused on some change in the requirements for treatment planning. Hopefully you are all familiar with that, but it is hopefully moving us in that direction of really to make some of those changes we're looking for. In addition to that, we're doing some work with CMS. We are looking and going to put in a request to move our clinic into the rehab option, which for those of you who might not be as familiar with the state plan, it's similar to what OASIS has already done. So we're really looking to align with them and how they are, the direction they're moving in with their clinics. Additionally, work that's happening is, updating guidance, especially based on some of the changes we made with the regs. But I think even more so as we move to a potential change with the state plan, and looking at other areas of things we can update. Updating the standards of care to start specific to the treatment planning, and then other areas in the regs that we may be able to make some changes that can be helpful. So we're really looking at everything. And like Boris said, the important part of the listening session is really, the interactive discussion with you all, hearing your feedback, your thoughts, even best practices you're doing, barriers that you think get in the way. Those are all things that can be really helpful information for us to have and work with as we move in this direction of really taking a look at all things clinic. So next slide. So the agenda today, we'll talk about, the purpose of the listening sessions, really to provide an overview of access, engagement, and return to treatment. What do we mean by these terms, so that we're all on the same page as we're discussing this? Breakout discussion groups, and again, that's the place where will be the interactive discussion. So we're really hoping for some participation there. And then coming back and having a report out so that everyone can hear all of these other discussions. We will be breaking out into smaller groups so that it's easier to have those discussions, and that people, everybody feels like they have the opportunity to speak up. And so we'll come back with that report out. And then lastly, we'll go over those next steps. Next slide. Okay, so the purpose of the listening sessions: to hear feedback from providers. Again, really focusing on, what do you find as barriers, maybe ideas that you have that, other requirements right now might be getting in the way, best practices, general feedback, any information you have is really what we're looking to hear. To provide the overview of access, engagement, and return to treatment in clinic. And what do we need to look at to get there for those things? Whether it be regs or guidance or standards of care, how can we move in that direction to improve those areas? The discussion around the breakout for access, engagement, and return to treatment. And then the report out, which will be the brainstorm of those best practices. And I'll even add to this, and although it's not the purpose today, but the larger purpose as part of even the next steps is that we will be bringing all the information that's being discussed in all the work groups together into one document. So we'll be sharing everything with you guys at the end. So you won't be missing out if you're only attending, one listening session, or you're not part of a specific listening session. We'll be bringing this all together at the end. Next slide. So definition of access: getting the right service at the right time in the right way. We want to make sure that all individuals who are seeking services get the right service at the right time in the right way when they need it. So we know right now there's federal, state billing requirements that can be barriers, but I would also encourage you to look at agency requirements and policies and procedures that could also be unintentionally put up as barriers to access in your organization. Sometimes there are things beyond, the federal, state, or billing requirements. So I think if we work together, we can really improve on that. So what do I mean by right service? So providing the right service according to the individual's needs. Not all first appointments necessarily need to be intake or assessment. Programs might consider ways to increase the ability to provide the right service, which could be potentially medication management earlier on in the appointments. Right time. Scheduling appointments in a manner that's individualized and flexible for people. Making weekend or evening availability for appointments. Also, scheduling appointments that utilizing potentially open access as a tool to support individuals. And I think also here, and I'll mention this actually a couple times, you can really utilize data within your agency to help determine what that might look like for you or the people you're serving. So this will be my first mention of it, but I'll mention it in some other areas too, because I think this can be really helpful to see what is happening in your clinic. The right way. Community responsiveness for things like offsite for individuals who might need to be seen in their home or the community. Now we have a large focus on telehealth, so maybe expanding that or looking at that. LBHP, which is specific to managed care, limited crisis. If we are able to move into the rehab option under clinic, offsite services will be an option for clinics to provide. Customer service training for administrative and clinical staff. And then lastly, individualizing pre-admission. Not everybody needs to have 3 pre-admission visits, but not everybody only needs 1 pre-admission visit. So really individualizing that. Next slide. So to improve access and engagement, there are really 3 very important areas to focus on. It's not just one area. So I'm going to kind of break that down to help us make sure that we're talking about and covering each of the different areas in our discussions. So to start, customer service, looking at things like physical plant, developing a waiting room that's welcoming, ensuring messaging of hope and inspiration in the waiting room, engaging signage that has positive feedback for people in the waiting room. Technology, scheduling, allowing for additional ways to schedule, making it easier, like texting, patient portals, places where you might be able to self-schedule. Looking at your phone system, how easy is it to get through and get to speak to somebody on the other end versus a never-ending decision tree. Communication and training. Administrative and clinical staff benefiting really from that customer service oriented training. Making sure clinical staff are trained in cultural competence, trauma-informed approaches, justice-related experiences, LGBTQ, racial equity, and implicit bias, including supervision in that, really allowing supervision to focus on staff communication and the customer service aspect of things. Policy and procedures. So it could be helpful for agencies to really look at clinical operations to identify if there's any barriers to clinic treatment for individuals. You want to make sure you have policies for managing wait lists, open access, referring out, risk management, engagement and re-engagement efforts. And again, this is where I'll bring up the data again, utilizing your data to help inform your development of policies and procedures, looking at service utilization and outcomes, referrals, screenings, and admissions compared to treatment drop-offs. That can really help to guide you in that work. And the one we're probably most familiar with is the clinical engagement piece of it. And so really, avoiding things like readiness for treatment, or, what we say is betting against the individual returning to treatment or engaging in treatment. Using gain-framed messaging, not punitive language. Provide training and supervision to clinicians around the clinical engagement piece. So not just, case reviews necessarily, but these other pieces as well. And then of course, meeting the individual's needs, connecting them with a peer, or really doing work that is more collaborative rather than directive, messaging hope and recovery. Next slide. So return to treatment, what we're looking at is how do we allow an individual to come back to treatment who may have been discharged to lost a contact, but also, maybe somebody who met objectives and goals and then would like to come back to services. And how do we make that easy for the clinic and the individual to really almost re-engage them, but it's more of a focus on the return to treatment. So things that we want to look at are return to treatment date, pre-admission status for return to treatment, assessment, looking at the comprehensive versus a screening or rescreening or reassessment, treatment plan, the initial and reviews, utilization review, discharge, electronic health records. Those are all things that really need to be taken into consideration for return to treatment. And right now, there's nothing in the regs that say we can't do it. There's no official policy saying you can't have somebody return to treatment. And it reduces readmission burden for both the individual and the clinic, which really allows access to treatment immediately. And our hope is that with the recent changes to the treatment planning section of the 599, those changes should help support a return to treatment. Some of those extended timelines for when treatment plans are due and required signatures. Other things that you might want to consider for operationalizing it, really allowing for immediate and easy access to getting back into treatment. Wait lists for individuals coming back to treatment. How do you identify the person if they're returning to treatment? Not delaying treatment. So if medication is something they need immediately, getting them into that medication appointment. Prior treatment plan could be utilized, a prior assessment can be utilized. And how do you look at what that means for the clinician for adding on to those assessments or adding on to the treatment plan? And really allowing a focus on the presenting problem and an identified needs. So even looking at closed charts and how do you re-access them and open up a chart back again. Next slide. So just like for access and engagement, the same areas are just as important to make sure that there's a focus on in this work. Customer service, which is things like access to return to treatment and what that might look for the individual. Policies and procedures, things like I mentioned, how do we reopen a closed chart? How do we access that electronic health record so clinicians can easily pull up information from a previous episode of service? Clinical engagement, potential opportunity for the individual to return to the same clinician. If there was a good working relationship and providing individual choice in that, if they're interested in returning to the same clinician. Okay, next slide. So like Boris mentioned, we were very quick on the presentation piece of it today, mostly just to get your minds thinking about these concepts, and really the plan is to move into these breakout groups and really have some deeper discussion in each of the topics. We will do a 45-minute open forum with a facilitator. Any volunteers, of course, to report out from the group is welcome. We are going to have specific, I don't know how many groups we're having, so we're going to come back to that, but we'll break out with specific areas to discuss so that we